It's Dr. Deukmedjian. This is September 30, 2021. And we're getting ready to start our fourth surgery for the day, and our patient is here from Canada. And I'll tell you a little bit more about him once we get started. But for now, this is Dr. Deuk. We're going to get started, okay? Can you hear me? I'm going to give you some numbing medicine. Everybody agree this is the left side? Yep. All right. I'm going to give you some medicine. You'll feel a little stick and burn, okay? Good. All right, Ativan's wonderful stuff. You said Ativan or Versed? No, Versed. So let me tell you a little bit about this patient. They're from Canada, which we have a lot of patients from Canada. But this patient has what's called a lateral disc herniation. Basically, it's a herniated disc that is to the side of where discs normally get herniated. Blood pressure good? Good. And it's in what's called the foramen, the neural foramen shot, lateral. So the disc herniation is off to the side. It's not near the center of the disc or just paracentral, we call it. It's really a far lateral foraminal herniation. All right, I'm going to show you what I'm talking about in a minute. Let's move south a little bit. I need to see the sacrum. So he had surgery done in Canada, and he basically has the same symptoms after surgery. All right, let's drop the table half an inch to an inch. Drop. Good. There. That's it. No, it's too much. It's too much. Shot. Yeah. I mean, do you know what half an inch to an inch is? It has an overshoot on it. Good. Perfect. Let's leave that. Let's see. All right, I can work with that. Let's wag it to get 3-4. We're doing 3-4. Okay? So first thing I need to do is get my fluoro in position relative to the patient. The patient's not moving. We need to move the fluoro. That looks better. So 5, 4, 3. There's 3-4. Look at that beautiful spine. Huge foramen. Show them the neuroforamen. That's the place where the nerves come out of the spine. Remember, the spine has two purposes. That's it. Perfect. The spine has two purposes. Number one, to give us support and support the weight of our bodies, our organs, everything is just attached to the spine. And then number two, it's to protect the spinal cord and nerves as they travel down from our brain down to our extremities and organs. And so the nerve comes out right where that white arrow is, okay? And this patient has a herniated disc right there in the foramen. So, and that's at L3-4. So 5, 4, 3, the arrow's at L3-4. You can keep it there. I'm going to go in and get into that herniation through the foramen. Now, can you all see here? Can you see, or do you want to use a different light? Let's use the different light.
Yep.
Let's get the other light. I want you to see the prior surgeon, what they did. Can you all see this? Can you see
Yep.
this line, this dark area right here?
Yes.
That's the surgeon. That's the incision that the other surgeon did, from there to there, not in the middle, but off to the side. It's called a Wiltsy Approach, and this is how every other spine surgeon but me approaches the foramen, a foraminal disc hernia, and it is horrible. Just under here is all of his muscles, and this guy, the other surgeon in Canada, just destroyed so much muscle. You could see it on the MRI. It's all white, it's all swollen and horrible. All right, so we're going to go in and get the lights back. I'm going to go through the foramen. I'm not going to remove any muscle or destroy any muscle. We're not going to take any bone out of his spine at all. We're literally going to go in straight into the herniation. I'm a little higher than I want to be. 5, 4, 3, 3, 4. So part of the reason, look, the surgeon didn't even go to the right place. Okay? So the herniated disc is here, and the surgeon's center of the incision is here. I'll show you. It's actually quite interesting. Let's have this. So we're going to line this up with the center of the incision. Shot. Okay. Shot. Look at that. 5, 4, 3, 2. 2, 3. So the center of this incision, you all see that? Is lining up with the wrong disc. Shot. Yeah, That's the wrong disc. I'm not laughing at this poor patient situation, but I'm laughing at how shitty so many surgeons really are. Shot. So I'm going to show you the right place to be. Shot. Now he doesn't even know this because I didn't realize the surgeon went to the wrong disc. Shot. Until just now. Otherwise I would have told this patient. Shot. A lot of scar tissue. Shot. Shot. Let's get an AP. Let's see where we are. So the white arrow, can you see the white arrow, Diego?
Yes.
Mm-hmm. Yep, that's good. Now back to a lateral. The white arrow on the side view is actually at the proper disc level, the L3-4. We all agree, right? I just want to make sure it's L3-4. L3-4. So, yeah. All right. Shot. Shot. Is he awake? Are you awake? All right. Can you hear me? All right. Just relax. Everything's going good. It's Dr. Deuk. What I'd like to do is get an AP. What's going on? How come you're relieving? He has to leave at 5? Huh? Oh, is he working tomorrow? All right. So, interesting. Just at the facet joint. Let's go back to a lateral view. I know what's happening. They remove the facet joint. Or at least part of it. Very interesting. All right. Shot. Shot. All right. Are you awake? I need his cooperation. Are you having any pain? No. No. Perfect. All right, I need him completely awake, so let me know when he's 100%. All right, I need you to show me where we are. I can't see the sacrum, and I just need to see the sacrum. So our table could go, could you open the collimator just on the one side, the bottom? The right side up there. It's the, yeah, that's perfect. Shot. All right, so maybe we shouldn't have moved south so much, but just a little more north, about 1 inch. You may need to wag a little bit. All right, that's perfect. Now I think you might need a wag. So that's 5, 4, 3, 3, 4. Let's get the pedicle of 3 lined up properly. Tell me how he's doing.
Richard, how are you? He's doing okay.
Are you having any pain? You'll let me know if you do, okay? Shot. Do you feel anything? In your back? Down your leg? Not in your leg. I love it when my patients are educated and prepared. You are the one. Thank you. We're going to have you asleep soon. Still in the back, right? The back. Shot? Yeah. I understand. That's the bad disc. No. You're doing great. Don't move. We're almost done. So, I'll show you something when you watch your surgery later. This is the, I've shown the audience and you the incision that the other doctor made. And I marked it on your back, okay? You can see it. And now I'm going to take this dilator and I'm going to lay it out in the middle of the incision, and you're going to see, shot, that the surgeon went to the wrong disc, I believe. Well, we're not going to get to the wrong disc. We're going to fix your disc the right way. We are just about ready for your favorite part. Now, you told me you don't have a lot of back pain, do you?
Correct.
And it's really just the leg?
Yes.
Do you get any back pain at all?
I think you once, so that I'll get 3 or 4 days of back pain left.
Is that the pain you get? Yes? How bad is that on a scale of 1 to 10? All right. You get to go to sleep now. All right? Count from 1 to 100. When you wake up, we'll be done with your surgery. Congratulations. So this is the L3-4 disc. Not there, but actually here. And what our patient has is a tear in the disc wall called the annular tear. And the jelly from the center has now moved out through the tear. And it's pushed through the tear, and it's gobbing up right here, just jelly. We call it a herniation. The problem is the nerve comes down the spine, and it literally leaves the foramen right there and goes down the leg. There's another nerve that runs just past the herniation and goes out the next disc and down the leg, okay? And he was wondering why one disc can actually affect 2 nerves. I was explaining that to him before. You can see there's a big tear in the back of the disc. The arrow's on it. So the other surgeon, I believe, went to the wrong disc. I don't have any proof of that, but that's what it looks like to me, because he didn't really do anything for this disc. Do surgeons go to the wrong disc all the time? Unfortunately, it's very common in spine. The reason it's so common is, number one, the lack of proper training and attention to detail by the surgeon. Number 2, the fact that the equipment they use is substandard. Like they use, all right, let's face it, this x-ray machine that you were using is the best in the world. It's a Siemens. And I don't get any money from Siemens for saying that. But the truth is that it is the best. It has the best picture, the crispest, clearest picture there is. And I can see everything with this x-ray. Now, when you have a heavier patient, it's harder to see. But with this x-ray, I can see so much detail. And with a cheaper x-ray machine, you lose that detail, shot. So I'm looking for there it is. I'm looking for the guide wire. You can see it's sneaking out to the right of that. Show them the guide wire on the right of the cotton ball, or the, not cotton ball, the dye. Yep. Do you see it? You got it. Monica, you're the best. So now we're taking our needle out. We're leaving the guide wire in. Shot. Want to make sure I haven't moved the guide wire, and I have not. So the guide wire is going to guide me safely. You got to watch your fingers there. The guide wire will guide me safely to the herniated disc. The only damage I've done to this patient, and the only damage we're going to do, is this cut right here, 7 millimeters. No other damage will be done. Why? Because under the skin, this skinny little tube will pass delicately, silently, gently through the muscle and directly into the tear. Once it enters the tear, then I can pass the tube that I'm doing the whole surgery. Okay, once I get the dilator into the tear, then I'll pass this tube. I'm doing the whole surgery through this tube, down the dilator, and it also will spread the tissue, and then I take this dilator out and I have a tube to do the surgery. Okay? Pretty nifty, huh? I did not design these tools. They were from a company called Richard Wolf in Germany. They're all FDA approved, and very, very elegant, beautiful system, very well designed. Really, in my opinion, the very best there is. All right, so let's see the sacrum one more time just to make sure we're at the right level. Shot. There's the sacrum. That's 5, 4, 3. Everybody agree we're at the right level? Monica? All right, so I'm passing through the foramen, and I'm passing through the facet. Shot. I know I'm safe because the guide wire is guiding this instrument. Without the guide wire, I would have great concern. Shot. But because I believe in this technique and the way it's done, I know the guide wire is in the right spot. I just felt the herniation shift from the foramen, and I'm driving it back through into the disc. I'm going to pull this guide wire back just a little bit. I don't want it passing too far forward. Shot. And once again, I'll resume advancing the dilator into the disc. Shot. Shot. And shot just means take a shot, take a picture. It's kind of a silly old term from the 80s. Shot. But it just means take a picture. What does Patel say? Picture, huh? Please don't let me get that. Shot. I don't know, I just like shot. I guess I'm old-fashioned. Yeah. What'd he say? Quick peek. Everything's okay. So he's sleeping. And once again, I have to advance this tube. Shot. And I'm doing that right now. Thank you, Luis. That's good. We're coming down nicely, nicely and carefully. Shot. Uh-huh. Beautiful. Shot. Shot. So, if you know of anybody with a hernia, it won't be too hard. If you know anybody with a herniated disc and they're considering getting it fixed to get rid of their pain, shot, this is the best surgery you can do, right here. There is nothing better. Open surgery sucks. It doesn't even work. And it causes so much damage and trauma under the skin you don't even see. But it's there. So we're going to fix this one disc, and I think he's going to be very happy with the results. We are inside the damaged disc right now, and we're going to move our tube backwards. As we go backwards, we're going to come through the tear and we're going to clean it up so that it'll heal properly. You can put that on, Luis. So we are passed through the tear. We push the herniation back through the tear, most of it. And now we're going to go inside this tube with our scope. And this is what the scope and rig looks. We call it the rig because it's more than just a scope. The endoscope is really this part here, this long, plus this hole and the fluid adapter for the irrigation, the light source, and then this little end here. I could take the camera off and show you the endoscope better. The camera and endoscope are sold separately. And this is a high definition camera. So we can see all the details very nicely. All right, so in we go to left, L3-4. I need the scope on. All right, beautiful. So we are inside now, inside the herniation, inside the scope. Let's wipe I'm going to wipe the end. Oh, yeah, we can't have that on. I'm going to just wipe this. Just get nice and clean. Don't ever leave the suction on, guys. For some reason we're a little more blurry than I thought we would be. All right, let me just focus a little bit. Yeah, I think this was focused for cervical. That's better. I need the laser. All right, laser on 30. All right, so we know we're at the right disc. We checked with our x-ray machine several times, and I've polled my staff as I always do, and everyone's in agreement. We're fixing the right disc. The disc is blue because, as I've mentioned many times before, the herniated nucleus pulposus actually degenerates over time from the effects of inflammation on the nuclear material, which then causes it to turn acidic. Acidic nuclear material binds the blue dye. Non-acidic or normal nucleus pulposus doesn't bind the blue dye. Let me have the cable. Can you release it a little bit? Your hand is trapping it. Let go. Yeah. All right. So currently we're debriding the annular tear. And the surgeon that did his prior surgery, I think just unfortunately, whenever you have a foraminal disc herniation, it means the herniation's in the neural foramen. It is a rare, unusual area to get your herniation, but traditional approaches like microdiscectomy don't work. Okay, they don't work. You must approach it through the foramen. And the only thing traditional surgeons, most spine surgeons have is the Wiltsy approach to the foramen, and it's terrible. It's a big incision like you saw, and it's a butchery. And you don't want that if you're the patient. They're just going to slice and dice all your muscles and soft tissues trying to get to that herniation. And in the end, they're not going to get to it because it's too medial for where they are. So if they go the traditional route, it's too lateral, but if they go this route, it's too medial. The only reason I'm able to get to it is because if you look at my approach, I'm going lateral to medial. So I'm getting the lateral part of the foramen and the medial part of the foramen. I'm getting both. And once again, that's because of the approach I'm using called transforaminal approach. You're going through the foramen. Understand what that means, right? Trans means across, through, and across. You're literally going from one side to the other. So no matter where the lesion is in the foramen, you have access to it, whether it's lateral or medial. You can get either one. Whereas the Wiltsy approach only gets lateral and extraforaminal, and the paramedian approach, which is the standard microdiscectomy approach, only gets, at most, you get medial in the foramen. So you're missing that middle zone of the foramen where this herniation is. That's why traditional spine surgery doesn't work for this kind of a problem. And to be quite honest with you, this surgery can fix any problem with the disc. All right, do we have any questions from the audience?
Yes, we have a question on Facebook. One of our dedicated viewers have been watching all of our streams today and has a couple questions. He has been inspired by watching your surgeries and has a couple questions about the herniations. He has one small herniation in his neck but doesn't cause pain, and an even smaller one in his thoracic and gets a lot of pain. He wants to know that, based on your experience, why do some herniations cause pain and others don't?
Good question. Why do some herniations cause pain and others don't? The answer is inflammation. Inflammation, my friend. Pain comes from inflammation. So when there's no pain, there's no inflammation. And what it really means, if you understand what I'm saying, is that the people who have a herniated disc and no inflammation, they don't have pain. So how do you get rid of the inflammation? The answer is it's all in the healing process. The people that don't have pain in their disc have healed their disc herniation to the point that there's no symptoms. Generally what that means is they've walled off the nuclear material, they've formed a wall around it, and that wall has concealed and contained the leakage. It's kind of like nuclear waste. What do we do with nuclear waste? We put it in a giant cement bunker and we wall it off and contain it so it doesn't leak out. That's what has to happen. You have to wall off the herniation. Your body does that through the process of scar tissue formation. You form collagenized scar around the herniation. That's why we see so much collagen and scar tissue inside these herniations, because the body is trying to wall it off and stop it from being inflammatory. Okay, just like you would wall off nuclear waste and stop it from leaking into the groundwater or getting into the air in dust. You've got to contain it, okay? So why do people have herniations and no pain? Because they've successfully contained the jelly, the nucleus pulposus jelly, and walled it off. The nucleus pulposus jelly is that radioactive slime or sludge, whatever you want to call it, material, all right? And that's what has to be walled off. The problem is most people are able to wall it off, but some people can't. So this is an annular tear. You can see through and through there's the blue stuff. It's like a cake, like a wedding cake with different layers. And all this stuff right here that I'm lasering through is just nucleus pulposus stuck inside the annulus fibrosus, causing pain. So to answer your question, the vast majority of people can actually heal their discs herniations by walling off the herniation and making them biologically inactive. Biologically inactive. That's the key. Look at the crisscross pattern of the annulus fibrosis. You see the crisscross? That's something you read about in textbooks, but you never get to see. Well, here you get to see it because we're inside the disc and we're looking at it. That is the crisscross pattern of the annulus fibrosus. Now, some people just have symptoms from their nerve getting crushed. So it's not a chemical problem, it's a physical problem, a physical crushing. And that's what's happening in this case. This patient has a herniation that has created a lot of scar tissue, and that scar tissue has mass. And that mass is now pushing on the nerve, causing the nerve to be compressed. And so this patient needs a real decompression. And that's what I'm doing right here. I'm decompressing, I'm removing this herniated material with the laser. You can't remove this stuff with the normal surgical tools. This is all scar tissue right here. You can tell it's a different color, a different texture. It doesn't have the crisscross. It's all just inflammatory scar tissue. His body walling off the herniation. Over years, by the way. This is not an overnight activity. Unfortunately, people with biologically active herniations, they end up having symptoms for many years, most of the time, because they just cannot heal. They keep re-injuring what they've healed. I'll be done in probably 5 minutes, doctor. So we have one more surgery to go today. It's another single level, one level. It's L4-5. And this patient we added on yesterday because he was just in so much pain. He didn't want to wait till I get back in 2 weeks to do surgery, so I don't blame him. He has horrible leg pain. So we're going to go in and unpinch his nerve root because he has a herniated disc just like this patient, but not quite so much in the foramen, more paramedian, paracentral. And but same thing though, pretty much a herniated disc pushing on the nerve root, irritating the nerve root chemically, causing horrible pain. Look how thick this stuff is. This is not normal annulus. So when I showed you the crisscross fibers, those are normal crisscross fibers of annulus fibrosis. But this is not normal annulus. It's so thick. It's just thick from inflammation. So what I'm basically doing is debulking this herniation internally. I'm going inside and I'm just removing it piece by piece internally from inside the disc herniation. Nice thing about it is when you debulk things from internally, you don't damage the normal things on the outside. This is a strategy that I learned as a neurosurgeon at University of Florida in Gainesville. If you're approaching a tumor that's pressing on the brain and other vital structures around it, you can actually open the tumor, go into it, and start taking it out from the inside out. And what that does is it keeps you from damaging other structures on the outside of the tumor that are stuck to it, that you would normally damage when you're manipulating the tumor, trying to roll it and debulk it externally. Plus, most of the blood supply to tumors is outside along the wall of the tumor, so you get to avoid getting into blood supply of tumors by internally debulking them. Anyway, I'm internally debulking this disc herniation as well. But it is taking a while because it is a big herniation. And look at all this scar tissue. This is the herniation. This is the scar tissue. It's a golden color because of all the calcium inside of it. There's calcium because the body responds to abnormal tissues by calcifying them. We don't normally have this much calcium in our tissue. We call this dystrophic calcification, spelled with a D. Dystrophic calcification is part of the body's attempt to heal the tissue in a way. Nobody really understands why it happens. kind of reinforce the tissue, I guess. Look how nicely the laser just zaps away all this stuff. It takes a while to do, but it's still very efficient. Much better than anything else that's available. The laser is truly the best tool for this. Phew, amazing, huh? Very scarred in. This is what was pushing on his nerve, by the way, in case you're wondering. All this scar tissue, look at it. Just a big mass of it. A mass, like a tumor. Except not a cancerous tumor, just a mass. Tumor means mass. And of course it's Latin, as is most medical terminology is Latin based. Tumor, mass or swelling. Five more minutes. This is taking longer than I thought. It's a lot more material here, and it's very collagenized. Whew. That is bad, huh? How's he doing? Yeah. A little bit of inflammatory tissue right there at 12 o'clock, that pinkish stuff. But this is all the herniation and scar tissue around it. Huh? You never want to pull on the endoscope when you're trying to get more medial. You always want to pull on the tube. Just a little trick. If you pull on the endoscope, you will break your endoscopes. If you're a surgeon out there watching, wanting to do these surgeries, you have to pull on the tube, not the endoscope. The reason is the endoscope is very delicate. It has lenses inside, and if you are too rough with it, it will break. And then you'll be spending thousands of dollars to fix it or replace it. Well, I've done my fair share of endoscope breaking, trust me. When I first started using the endoscope, I didn't understand why it kept breaking, and then I realized it was my brutal nature to break endoscopes. All right, Diego, any more questions?
Yes, we have another question coming from Facebook. We have a guy. He says that he likes that your procedures are very easy to recover from.
Yeah.
One day. He says he likes it because he does CrossFit, travels the world, and rides theme park rides. He's had already 2 Bonati surgeries.
Sorry to hear that.
Bonati surgeries.
Yep. We don't say that name here.
Okay.
I'm just kidding.
The one who should not be named.
Yeah, exactly.
Yeah. And they told him that he might not ever be able to ride a roller coaster again in his life. He said this was shocking to him because no one had warned him before, but they quickly reversed that and said that if he strengthens his neck enough, he will be able to ride roller coasters again.
Yeah. All right. Well, I'm sorry to hear that you went to the Bonati Institute. I would never go there. You know, all I can say is we've had to fix a lot of patients that went to the Bonati Institute after they went to the Bonati Institute. If you go back and watch a posterior cervical fusion that I did about 2 months ago on YouTube, and there's holes in the spine that the Bonati Institute put in there. They basically fractured his spine from drilling holes in the lamina. Kind of like a microdiscectomy of the neck, And we had to do a fusion. And you could see this, he was almost paralyzed from their procedure. They just were so irresponsible in how much bone they took away. They just went crazy taking bone out. So I'm not sure if there's a question in there, but I genuinely am sorry that you've had that experience. I'm not sure if you're asking me, can you do the roller coaster? I don't know. I'd have to look at your neck. But for my patients that have this surgery, they can go back and do roller coasters, 100%. They just can't do it the next day. You have to wait a year. Let your discs heal, and then you can go ride a roller coaster. If you're having this procedure done and you want to ride a roller coaster, no problem, but you got to wait 12 months. 12 months after surgery to go ride a roller coaster. We are just about done, and this was a tough one. Look at all this. I mean, this is as thick as it gets. This is really tough, thick herniation. I've been able to clean it all out, but it's taken a while. A lot of laser energy. Where are we at on laser energy? Probably somewhere in the 30s, close to 30. $30 joules. Huh? 29.1 joules. Not bad, huh? I'm pretty good at this stuff. Yeah, but we've gone to 64, not on one disc. No. Don't argue with me. Oh my God. Oh my God. All right, so she's saying we went to 60 on one disc. That's our record. You know what? I believe her because she's very smart. And that's the only reason I believe her. I trust her. She's our OR circulating nurse. And I've learned not to argue with smart people like her. Okay? So, all right, so 30 is not so bad because we're just about done. I just don't remember delivering that much energy to one disc. We did? All right. So are you just calling me a complainer for no reason? Huh? It was super late at night. I love it. Super late. It was 8:30. God, you make me sound like a monster. Super late, 8:30. There is no way. We were operating at 8:30. You serious? Or, but maybe the patient went home at 8:30, but I don't think we were operating at 8:30. All right. I'm not going to argue with you. Huh? Yeah, I remember. She what? Yeah, exactly. All right, well, we're pretty much done. I just want to have one more look. This is the end of the disc. This is the foramen. We are in the foramen. And there's no more herniation. It's gone. I basically zapped it away. There's bone up here. There's posterior ligament right there, those fibers. This is a little bit left of the scar tissue. No big deal. It's not pushing on anything. And you can see we're in the foramen. The nerve root is going to be right up there. I'm going to take a little more of the scar tissue out just to make sure we don't leave anything that could cause problems. Gosh, you can see some of the hemosiderin from his prior surgery. Some blood right there that's kind of like old blood. You know, old blood takes a long time to go away. And a lot of scar tissue. I did not like that. think we're pretty much done. I don't see anything left. All right. Scope off.
Lights on, please. Here, scope off. Stop my button.
Little antiseptic there. We're done. I'm happy. I don't see any more herniation. Lay still. Everything's okay. Lay still. You're doing awesome. We're done. You're not going to be happy until I get this tube out. Need the dilator. 32 joules. All right, let's get this out, make him happy. Lay still, you're doing great. We're done. Come on. All right, so we just put a little bit of pressure just to keep the muscle from oozing, get the bleeding to stop. Lay still. You're doing great. Dr. Deuk here. We're all done. So he's waking up now, and we're done. We're going to put a stitch and a Band-Aid. You can see the whole surgery was done with this little cut. You see that there? Diego? I hope you saw it. I'm not going back.
Yeah, we saw it.
All right. All right, so type up your questions for me. I'll be happy to answer them. But we have one more single level Deuk laser disc repair. I think it's L3-4, left approach. And for those of you that are hardcore and want to stick around, no complications, EBL 1 mil. This is the left. No. Oh, this was left. So we had 2 lefts. I've got the best staff in the world working with me, especially when they remember how much laser energy we delivered. Yeah, you're entitled to have a weird memory. No, I honestly don't know.
If you did the round level.
If what?
If you did the round level.
Oh, no. If we have a specimen.
Deuk laser disc repair, a comparison with traditional spinal fusion surgery. A patient with chronic back or neck pain originating from a symptomatic disc injury could undergo either traditional spinal fusion or less invasive Deuk laser disc repair. This MRI represents a typical case with L4-5 and L5S1 symptomatic discs. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Deuk laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, 2 patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Deuk laser disc repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Deuk laser disc repair requires only a very small incision, usually less than a ½ inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Deuk laser disc repair,
We'll be live in 3, 2, 1.
Dr. Deukmedjian, we just finished the Deuk laser disc repair left at L3-4, and our patient from Canada had surgery on his back at L3-4 on the left side, but the surgeon missed the disc herniation, left it in there. Happens quite often. I think maybe even went to the wrong disc based on where the incision is. But you could see the surgeon that did his prior surgery, remember the herniation is here in the foramen, right there where the tip of the pin is, okay? And this is what all spine surgeons will see. But you have to literally remove all this bone and try to reach out there into the foramen laterally to get that herniation. And they just can't do it. So his surgeon made a cut here and basically cut through the muscle. And you could see all the dead, damaged muscle, and then came right here and then tried to get the herniation out. But this is what that surgeon's seeing. He's here, but the herniation is actually here in the foramen. So the surgeon missed the herniation, and just we went in there and took care of business. So we came in at an angle, past the facet joint, and ended up being able to get the herniation out. And I'll be honest, there was a lot of scar tissue and herniation, both. It was probably around 50-50. 50% herniation, 50% scar tissue. All the blue stuff is herniation. All the white stuff is scar tissue. And there was a little bit of calcification going on. But you could clearly see the nerve was getting pinched, and we got all the pressure off the nerve. This patient's leg pain should be gone, and I expect him to be very happy with the results. Any questions? All right, hope you enjoyed the surgery. We'll be back in 30 minutes for our last surgery of the day.